Hello, and welcome to our highlights podcast summarizing the key messages from the recent webinar, Early Use of Advanced Therapies in Lupus. I'm Ed Vitale. I'm a professor in translational medicine at the University of Leeds, and I'm joined by Dr. Guillermo Pons-Estel, who's director of the research unit of the Argentine Society of Rheumatology, and Professor Richard Furie, who's the chief of the Division of Rheumatology of the Department of Medicine at Northwell Health, New York, and Professor Chris Edwards, who's a consultant rheumatologist and honorary chair of clinical rheumatology in Southampton in the UK. Hi, everyone.
Hi.
Hello, Ed.
So, today we're going to do a highlight summary of what we discussed in the webinar from the 26th of November, which I chaired and which Guillermo, Richard, and Chris all presented at. The topics were covering the limitations of standard of care therapies, insights into early intervention in lupus from clinical trials, and how we strategically use early intervention with advanced therapies in practice, or how we might do that in the future. You can access the full on-demand webinar and all our more detailed discussions and Q&A from the individual speakers at www.lupus-forum.com, and you can watch that for free. So first of all, Guillermo, you spoke first, didn't you? And you spoke about the limitations of standard of care therapy. Could you just give us a rundown of the main points you covered?
Yes, thanks, Ed. The first question is, what is a standard of care? And we discussed that the standard of care, they don't have a specific definition, but mainly what we understand for the treatment of patients with lupus as a standard of care is the use of antimalarials, glucocorticoids, and immunosuppressive drugs. We have seen the different guidelines that suggest that this treatment it's part of the main treatment of patients with lupus, and is usually associated with the first line of treatment of these patients. I review some of the limitation of these drugs, and part was also said at the Q&A, such as the limitation of the use of antimalarials. We know that they are effective, but we know that they are associated sometimes with side effects, and we don't know until when we should or we could use these drugs, and if they should be for all the patients and forever. Then we talk about the limitations on the use of steroids. We know that steroids are associated with damage. Then we know that they are associated with a lot of side effects, and that whenever we try to stop the use of steroids, many of the patients tend to reactivate and have flares of the disease. Finally, about the third part of the standard of care, the immunosuppressants, we know that these are effective drugs that have changed the course of the disease, but also they have side effects. In some of this medication, we have problem with access, we have problem with pregnancy outcomes, and in part, this medication have shown to be effective, but associated also with side effects. Then I plan the idea about what is the objective of this standard of care treatment, and we know that the objective we may try to reach, or we want to reach, is Doris' definition of remission, and if not possible, low disease activity. And why? Because whenever we reach these objectives, we know that this is associated with less damage, less mortality. What I have tried to show is that using real-world data, that in many cohorts around the world, it's very hard to achieve the same points of remission on, and even more difficult, off therapy, showing that in some registries, it's up to 10% on remission on therapy and less than 2% of remission of therapy. And it's important to try to achieve this remission of therapy, because whenever we achieve this is associated with less damage. Also, we have spoken that it's important that this standard of care is early in the course of the disease, because early in the course of the disease, we have damage. Early in the course of the disease, we have high mortality, even more important in young patients. And part of the innovation of how to achieve better goals in patients using the strategy and the medications that we have, and new medications in part comes with the T2T strategy, try to produce and to have good outcomes for our patient, close follow-up of these patients, and that we have to make an early diagnosis. This was part of the things that we spoke, that is quite important to try to get early in the course of the disease for the diagnosis, because over there we have the window of opportunity to try to treat this patient and prevent damage. Finally, we spoke about changing the paradigm of the treatment, and instead of treating with antimalarials, glucocorticoids, and immunosuppressive to all patients, and then escalate only when we have a really active disease or refractory disease, we have seen that most of the guidelines are changing this paradigm from the treatment of early disease with more aggressive strategies, mostly for mild refractory disease, for moderate to severe disease, in a way to try to then taper the use of steroids. Finally, I mentioned some of the innovation coming from clinical trials, and this is part of what I believe that then Richard mostly talked in his talk.
Yeah, and then in the discussion we covered some of the points about whether people could, or even without waiting for advanced therapies and new trials, whether people were already trying to make kind of earlier interventions with more intensive treatments in a preventative manner in certain patients, weren't there? And you were sort of cautioning a little bit about that, I think, weren't you?
Exactly. Exactly. We mentioned this that there are some trials that have tried to use, for example, mycophenolate early in the course of the disease in patients with not very active disease, in a way to see if this will impact on the long-term outcomes of these patients, showing some promising results. So this was part of the discussion as well.
Okay, so then if I hand over now to Richard. So you talked about clinical trials and what they can tell us already, didn't you?
Yeah, so the title of my talk was Insights from SLE Trials. The topic actually was very challenging because the question that I was trying to ask was, can our current trial designs inform about the benefits of early use of advanced therapies? So it'd be an easy question to answer if we took out the word early, but in fact the word early is there. So I interpreted this question to mean, can we see long-term benefit in our short-term clinical trials? Because, I mean, in our SLE trials, and for that matter in our lupus nephritis trials, we don't discriminate between patients with long-standing disease versus patients with disease of short duration. So I think we need to rely on surrogates, and that's what I stress. Activity and damage go to the top, because we know that activity begets damage. There was a lot of discussion in this podcast about activity and damage. So activity begets damage, and damage begets more damage, and damage is linked to an increase in mortality. And I showed some of the data behind these statements from University of Toronto, and then a meta-analysis linking damage to an increase in mortality risk. But to try to get back to the question, which clinical trial metrics could inform whether early intervention is beneficial? And I focused on activity. SLEDAI, BILAG, SRI, BICLA, doesn't matter what you do or what you use, but a reduction in activity intuitively is very good. And I showed, actually going back to about 2011, when I was bombarded with questions about what is an SRI and what does it mean? And so we did correlations between SRI response and metrics that one would use in everyday practice. And then along came LL-DOS and DORIS, and certainly those disease states are associated with a lot of clinical benefit. Then I moved on to damage. And though we have the damage index, the problem with our clinical trials is that they're too short to see a difference, say in 1 year, or even for that matter in 2 years, of damage accrual rates between the experimental drug and standard of care versus placebo and standard of care. So we needed to resort to some kind of rather novel, clever strategy. And what was done was to take, for example, belimumab phase 2 extension data, and the extension was open label and it went for 9 years, but again, it was open label, so there was no comparator. So an external comparator was used, and that was the University of Toronto cohort. Patients were matched using propensity score matching, and the bottom line is it showed that patients who were in the belimumab phase 2 open label extension had less accrual of damage compared to the University of Toronto cohort. Now there are a lot of issues, a lot of limitations, but at least it's a start. And a similar study was done with anifrolumab, comparing patients in the long-term extension of anifrolumab, which went for 3 years after the initial 1 year, and again compared to the University of Toronto group, showing that biologic treatment was associated with less damage accrual. So at least suggestions that if you want to prevent damage, which is the name of the game, then intervene with a biologic, and it would make sense to do it earlier than later. I then showed examples in lupus nephritis, where our trials have morphed into 2-year endpoints for the most part, and that has afforded us the ability to look at eGFR slope over time. And we've seen a numerical and in many cases statistical difference between placebo plus standard of care versus the experimental drug, be it belimumab, voclosporin, or obinutuzumab. There's not a whole lot of subgroup analyses that try to answer this question, but indirectly looked at the anifrolumab phase 3 program, where there was stratification between disease onset in the pediatric age group versus the adult group, adult onset. And the response rates were much lower in those who had pediatric onset of disease. And it's kind of supports, what I see when we are given the pediatric patients to our care. They are sick. They are tougher to treat. So again, it would just argue for earlier intervention. And somewhat similar message from the obinutuzumab subgroup analyses in the Regency phase 3 trial, where patients who were previously diagnosed had a lower response rate to obinutuzumab compared to those newly diagnosed. So again, suggesting early intervention is better long term. There is a study, it's called Be Early, and that's with belimumab, though it's open label and it will go for about 3 years. The rationale for doing this Be Early study is because of the high degree of damage accrual in the first many years of diagnosis. The idea is to take 350 patients with early lupus, that is less than 2 years since their diagnosis, and intervene with belimumab. It is open label. The endpoint is LL-DOS at week 52. So there will have to be a historical comparison. So in summary, using essentially surrogates, relying on activity and damage, I think you can show that short trials of 1 year or 2 years duration translates into long-term benefit. So I thank you.
Okay, so in other words, even though we don't have early intervention trials yet, it should be reasonable to extrapolate from the established trials into
Absolutely
early
Yep.
populations, but hopefully in future. And then another point that came up in the discussions, I think that's quite relevant to what you were saying about subgroups, is that some of the things that Chris showed that predicted who's going to do the worst in the natural history of the disease, like high double-stranded DNA, low complement, high SLEDAI, those correspond to some of the best responding subgroups in trials.
Correct.
Yeah. Okay, thanks. So I'll go over to Chris now. So you talked about how this works in terms of sort of developing early intervention strategies and identifying appropriate patients and so on, didn't you?
Yeah, so I spent some time thinking about if we are going to treat early, what are the sort of things that we might need to do and know about our patients to predict who might do badly, who might be the most important to treat early. Um, I started off by talking a bit about the barriers to doing that, to treating people early in a clinic, and how those might be around patient concerns about new treatments. It may be the need for all of us to be educated in the treatments we use, the complexities sometimes of lupus, how sometimes the reliance on high dose steroids can move on the treatment early enough. And one of the main things was us having reliable ways of stratifying the patients into different groups. And I spent a bit of time thinking about those things, starting with some clinical examples. You know, there are individuals from certain ancestral groups. I had the experience of working in Singapore for a bit, and I talked about that. And that population suffers with very bad lupus. And so some things about a certain Asian ancestries, certain Latin American ancestries that Guillermo mentioned in the discussion as well, certain African ancestries might be in the clinic, ways of predicting who will do badly. Um, we talked a little bit about damage accrual being early, which was a common theme of what we talked about this evening. And then other things that might help us to decide who will do badly using some of the cohorts that are around, the SLIC cohorts, and also some cohorts from Canada as well, from Toronto, and looking at features that were more likely to be associated with people doing badly that might justify early treatment. And those things like renal disease and the racial groups that I've talked about, for example. And just the presence of more features of disease. So if you look at classification criteria, the more of those individual components of the classification criteria you have, the worse you tend to do. Then there's a bit of AI that we talked about. People are starting to try and use AI and machine learning to pull together features that might help them to predict who'll do badly. And some of those are the things I've mentioned already in some of the models around presence of lupus nephritis, neurological disorders, etc. And then we spent a little bit of time also looking at serology, autoantibodies, and how the presence of certain combinations, you've mentioned some of those already, Ed, so having high double-stranded DNA antibodies and certain combinations of that presence of anti-SM and anti-RMP together. And various colleagues, I mentioned Karen Kostenbader's study where they looked at different clusters of patients, 800 odd patients, and came up with those that did badly, and those with anti-SM and anti-RMP were one of the groups that did particularly badly. So that might help us in the clinic to predict what we're going to do. If we look at the guidelines and recommendations that have been produced over the last couple of years, there's been a real flurry of them, but all of them point in a similar direction, really. And of course, recommendations are based on expert opinion. So our colleagues certainly feel this direction of travel, but also on the evidence base as well. And whether it's the EULAR recommendations, whether it's ACR, they all tend to say treat early, make the diagnosis early. We had some discussion around some of the problems and some questions as well, didn't we, from the people listening in around the need to be able to get people into the system early and diagnose early, and that doesn't always work. We might also pick on the basis of what the evidence says about who tends to respond, which groups respond to certain biological therapies, certain advanced therapies more than others. And there's some steer around that. You know, MMF, belimumab, voclosporin for lupus nephritis, obinutuzumab now, of course, anifrolumab for those with an interferon signature and skin disease. And you could go through, different therapies and the different patient groups that perhaps might respond more from the studies. And then I finished off with trying to find where there was some real world evidence from trials of actually treating people who had earlier disease. And we spent some time thinking about what is early. There's a bit of work from David Eisenberg's group in London looking at a group of patients given earlier rituximab compared to a population that didn't, and those having less disease activity on BILAG scoring and less use of steroids, so a bit of evidence. And then there is some Japanese data around belimumab where they divided a population of more than 100 individuals treated with belimumab, and they divided them into disease that was less than 5 years old and more than 5 years old, and those with earlier disease did better when they were treated. And then finally, having thought about the barriers, we talked about some of the practical measures, the setting up of early clinics, the setting up of high-risk clinics, and the importance as well for us as a community of producing health economic data to try and justify to the payers the need for these treatments to be used as well. So I think that's it.
Yeah, it was a lot of ground to cover. And something else that came up in discussion as well, wasn't it, was that about what you need to do to get patients to accept such strategy, or what patients need to know to.
Yeah, absolutely. And the importance of producing education for patients that's appropriate. Guillermo talked about some of those programs that are available in Latin America. There are programs around the world. There's information produced by Lupus Foundation of America, by Lupus UK in the UK, that can help with that. And then we were thinking about some of the things that encourage people and our personal experiences. For me, sometimes people will say, I'd really like to go on that drug doc as long as I can reduce my steroids. Lots of people really don't want to be on high dose of steroids, and that makes it easier for them to overcome perhaps concerns they might have from not knowing about some of the newer therapies.
Yeah, it's a difficult problem, but at the time of diagnosis, it's quite challenging for patients. So to
Yeah.
talk about these strategies is quite difficult. So I think that's all we have time for today. So thank you for joining me for these highlights, Guillermo, Richard, and Chris.
Thank you.
Thank you.
And I hope everyone found this highlight summary useful. If you remember to visit www.lupus-forum.com to access a variety of other content, and keep an eye out for future webinars. Thank you for your attention.